Okay, so we've got 13 participants. We're on 8 minutes past 6. And, you know, it's always the people who arrive on time get penalized for arriving on time because we always end up giving 5 minutes, 10 minutes grace to people who are coming late. But what I would probably do is just start off 9 minutes past the hour now, because we've got 3 really great speakers tonight. For those of you who have joined us already. And I want to give as much time as we possibly can to hear them and for you to question them as well. So some of you or most of you will be familiar with me by now, but if not, I'm H. Michelle Johnson. I am a nurse by background. I still work in the NHS, but I work in commissioning now, and moved over from clinical work into communication. So I'm head of communications and in stakeholder engagement at a clinical commissioning group. And in addition to that, I am an author twice over. My first book, Do Great Exploits, was published 5 years ago. And I'm just about to release my second book called Bouncing Back, which is about resilience. I also do radio. So I'm a radio host for the last 4 years. And I do talk shows of my own. Currently, I am hosting with a friend of mine, a program called Chat Back. And generally, it's about interviewing people about topical issues. And I enjoy doing that very much indeed. What else can I tell you about myself? I am a coach as well, qualified coach. I did my coaching for myself, really. But over the years, I've had the odd client, particularly around preparing for interviews. And I just love communicating. I love engaging with staff, with people, and encouraging them to fulfill potential and supporting them to do that. So that's a little bit about myself. I'll be the moderator tonight. Very briefly, again, we're looking at ground rules. I've put everybody on mute, but you have the power to unmute yourself. We just want to be able to give everybody a chance to speak. So if you do want to speak, please put your hand up and I will signal to you to unmute. And when it's your turn to speak, just keep it brief and to the point so that you know, as many people as possible can actually join in and speak so that we can have a really interactive session. We also want to be mindful, be respectful of other people's views. I mean, we haven't had any conflicts are, and I don't anticipate that will happen tonight either. The session tonight, oh, before I even say that, I just want to acknowledge the sponsors really of these events. So the Black History Month and Unison and your local reps from Unison, Loxley and Pat, have worked really hard to put together a program of events throughout Black History Month that really would empower, inspire, motivate, challenge, and encourage people to step up, to grow in their professional life. And so far, so good, I think. Our first event on the 6th of October, we had 2 amazing dynamic women who are pioneers, but you know, they're the types of women who have so many awards and even recognition on the Queen's Honors List. Joan Myers, OBE, and Paulette Lewis, MBE. They are nurses and are retired now, but in fact still very, very active in coaching and supporting people from Black, Asian, and minority ethnic groups working in the NHS. The second night we had Patrick Vernon and also the chief exec of Unison came as well, which to me really signals Unison's commitment, Unison's interest, not only in sponsorship financially for these events, but to have the chief exec actually come to one of the events, I think, and speak is really reflective of the concern and the commitment to invest in Black staff within the UCLH. And all along, we've heard of the various services that are available to you, one of which is the coaching service, which is provided free of charge for staff at UCLH, and is currently underrepresented by UCLH's Black, Asian, and minority ethnic staff. So this is free coaching that you can access, and we will put those details in the comments box for you. The other thing I should say is that there is a chat for you to put your questions and your comments, and I'll read them out for you as well. Okay, so thank you so much to Loxley and to Pat for this event. There are further events coming up, and we will remind you of what those are towards the end of the meeting. I'm so thrilled because tonight the focus is on health, and we are all health care professionals, whether we're clinical or managerial, administrative, whatever department we are working in. We're all working for the National Health Service here. So, health is an issue. That's why we're all working here. But we also need to, as health workers, remember to self-care, remember to take care of our health, because obviously we're human beings. We're not robots working in a health service. And I would say, even as a nurse, a former nurse myself, I'm the person least likely to show up at a GP practice, or least likely to access care. And I don't know if it's just my nursing thing, but I just want to avoid hospitals and situations like that as far as I can. And I imagine that I am not unique in that way. So I'm sure there's a lot of us in this audience who also perhaps are not as proactive about seeking access to their health services, various ones, as needs be. And I know that happens a lot in mental health services, for example, the increasing access to psychological therapy services, which are there free of charge, again, that you can self-refer to if you've got anxiety, worries, concerns, bereavements, anything that you're tackling that you're finding really difficult to manage. The IAP service is there free of charge for you to access. And again, it's quite markedly underrepresented by the NHS's BAME staff and patients as a whole. So we're looking at self-care and health tonight. It's the title of the session is Women's Health. Oh, sorry, bear with me. That was somebody else's title. I was just about to read there for you. Oh, it's Women's Health and Men's Health. Okay, very simple, very straightforward. We're wanting to do an overview of women's health and men's health. So it's both men and women who will gain from tonight. And we've got a really stellar lineup of speakers here, I would say. We've got Miss Susie Elneil, consultant, associate professor at UCLH. And I will introduce her properly in a moment as she comes on to speak. And we've also got Miss Jean McDonald, who is a consultant urological surgeon, and Ms. Bridgette York, who is a lawyer, but a women's health campaigner and a patient advocate, really, and has worked with organizations in terms of advocating on behalf of patients, particularly those from Black and ethnic minority backgrounds. So without further ado, I'm going to introduce our first speaker tonight, and that is Miss Susie Elneil. I'll tell you a little bit about Susie's background, if you bear with me. Okay, so Miss Susie Elneil, I think many of you would see her out and about. When I worked at UCLH, I used to see her and spoke with her on many occasions, although we worked in different teams. So she's a consultant urogynecologist and uroneurologist. She started her career in the field of urogynecology in the early 1990s when she became involved with patients who suffered vesicovaginal fistulas and female genital mutilation in the developing world. Despite surgery, many of these patients went on to suffer further problems with incontinence and chronic pain, pelvic pain. This formed the basis of Miss Elneil's career, which started in gynecology and then went on to subspecialization in the field of female pelvic medicine and reconstructive surgery, formerly known as urogynecology. Susie Elneil is also a teacher and trains colleagues in the UK and further afield. She has recently been honored with a visiting professorship in obstetrics and gynecology at the University of Ibadan in Nigeria, which is the oldest university in Africa, for her ongoing work in developing and instituting a new postgraduate degree in female pelvic medicine and reconstructive surgery, for which she is also a preceptor and trainer. So Susie Elneil has not just been a surgeon at UCLH and kept her head down, but she has looked further afield and is influencing in foreign countries as well. So I just want to welcome Miss Susie Elneil. It's my pleasure and my honor actually to do so. Welcome, Susie. I'll hand over to you.
Thank you very much, Michelle. That's so kind. That was a lovely and sweet introduction. I appreciate it. Well, it's a real honor to be invited to speak about women's health. And I'm going to start by sharing my screen just so that it's easier for us to discuss things together. So the remit today was really to look at women's health, particularly in the Black community, but really look, this could cross across all different other communities, Asian and minority ethnic as well. But this is really to look at the issues that we've had to deal with specifically. So I just thought we'd start off generically, you know, what are the problems that most women face? Well, we've got the inherited issues and we've got the external factors. And perhaps for women, the most two critical things are pregnancy and childbirth and the aging process. Both of those are always seen to be normal, physiological. So there's a tendency for people to overlook the issues that one comes across as a consequence of those conditions. And what you've got here is a bronze statuette from the 4th century BC showing, you know, that's the typical problem women end up suffering. So the impact of the central obesity and changes, the impact on the pelvic floor here is really one of the things women do suffer with. And this is generic, but it's interesting to see that there are disparities, changes, and influences because of race and changes because of culture. So who are the women? Well, almost all groups of women, you need to look at this because actually within the demography, the country of origin, the religions and the culture, all of them have impact on the type of health problems they can present with. So it's never generic, it's never the same thing. So each woman is an individual. And as her physician or her nurse or her medical worker, you need to look at that specificity really to help you gauge what to do for her. And I'm just giving you a scope of the problem. This is just to give you an idea. So most women throughout the life cycle can suffer with everything from pain as a consequence of childbirth all the way to things like prolapse, incontinence, abnormal bleeding, etc. And superimposed on that are the issues of mental health, which Michelle has alluded to, and that is an important factor because it is underrepresented, particularly in the BAME communities. It's not always picked up. And then the issues of things like domestic violence and so on. These are also issues that are not always picked up. They're taboo areas and people don't like to discuss them. So I thought let's just start off with sort of simple gynecological things. So an ectopic pregnancy is usually a problem that occurs when the pregnancy, instead of occurring in the womb, is occurring in the tube. And you would think that most women are don't have, you know, they do not have any, it can't be that different. If you're a woman, your risk is the same. Well, we now know, and this is a paper showing a look at ectopic pregnancy rates. And this is from the racial disparities looking at Afro-American women. You can see that, so people looked at factors and they thought it's the outcome at all. It is just the race. So ectopic pregnancy, the most striking finding was within this group of women. Now, Bridgette, who will be speaking on advocacy, patient rights, and so on, is an expert really on fibroids and heavy menstrual bleeding. But this is just to give you a broad overview. Fibroids are extremely common within the Black community. The management are numerous types of management, and the presentation is well known to many women who suffer it, so pain and bleeding and so on. Again, if you look at the racial differences, you can see that this is a study looking at 101 participants, of which 40% were Black, 57% were white. And you can see that within the Black community, 26% of those who had fibroids were Black compared to white women. So there is a factor here. So there was also an interesting secondary finding where they talked about the lining of the womb was much thicker in Black women. So the question then arises, does that give them a possible link to perhaps cancers later on in life? We don't know, but that's certainly something that needs to be reviewed. Now, one of the interesting things I found is that when I was training as a doctor, I was always told endometriosis, which is a condition where you have got basically tissue that's very similar to the lining of the womb, but present externally on top of the bladder, on top of the uterus, on top of the ovary, where it should not be, it should be in the womb, appears in those places, and it often causes significant problems with pain, fertility issues, and other complications. And this tissue can go as far away as to the lung. But when I was training, endometriosis was stated to be a non-Black issue. It was not a problem in Black women. So actually, there have been many studies since then where they looked at the issues of racial disparity, and they found that Black women, because the expectation was you wouldn't have endometriosis, that Black women were less likely to be diagnosed with it. Asian women were more likely to be diagnosed with the condition compared to white women. So this is an interesting thing, that depending on your race, you were more likely to get a particular diagnosis. But then the question arises, is that because you were not offered the assessment process? And in the best way to usually diagnose endometriosis is a laparoscopy. So if you haven't had a laparoscopy and you've got chronic pain as your main presentation, there is a tendency, if you're a Black woman, to be told, well, it's just chronic pain, it's something else. And I know certainly in a lot of environments, it used to be, oh, it must be PID, which is pelvic inflammatory disease, or it's just your musculoskeletal system, etc. So they were less likely to be diagnosed simply because it was not made available. Then you look at pediatric and adolescent gynecology, a very well developed field, particularly within young Caucasian girls, and this is very typical in the UK. There is a lack of expectation that this will be present in the Black community. And so if you look in the literature, there is no specific data in the Black community. Yet it makes sense that if you've got an abnormal vagina or an abnormal uterus, it should transgress all communities regardless. But what about the specific problems? Well, there's a whole group of specific issues that women tend to suffer as they age, particularly after childbirth. So things like stress incontinence, so leakage if you cough or sneeze, all the way to pain when you have sexual intercourse, or prolapse when the womb and so on can come down. And in between, there's a whole host of other symptoms. And these are the general ballpark statistics. This is just ballpark, 10 to 60% of women will report incontinence at some point in their life. 10% will complain also of incontinence of flatus or stool, and 50% of women who have children will develop prolapse, which is descent of the organs in the vaginal area and so on. But very, very few will ever seek help. And Michelle's point, particularly about health workers, is so valid here as well. So if you look at the developing world, it's less than that, it's less than 2%. But let's look at incontinence, which can be neurogenic, either nerve-related, so like multiple sclerosis, or non-neurogenic. And this is a study that looked at, sorry, we'll just go back. It's a study looked at establishing the prevalence. And it's something I learned in my training, and I saw it actually that there was a tendency for Black women not to have the stress incontinence, in other words, the leakage when they cough or sneeze, but to really have another form, which is known as urgency or urgent incontinence. So they rush to the toilet. If they don't get there, it can be overwhelming, and then their bladder loses control. And overall, Black women tend to have a higher score. So this is a quality of life score. They have higher needs. They have a huge impact on their quality of life. And often they tended to be more bothered. So there was a tendency to sort of perceive this as a perception, but actually what I found, and a lot of others have found, is a lot of Black women, when they are diagnosed with incontinence as a consequence of a hyperactive bladder muscle, actually the medication which is given to them, which often in other women groups will suffice, in their case you often have to double the dose or increase the options. So you have to double dose or double pharmacotherapy or other therapies and treatments. So it's quite interesting to see there is a completely different mechanism going on here. And this is just to show the stress incontinence. So this is a study to show that although stress incontinence is not a prevalent problem amongst Black women, this is taken from Dosu Ojembede, who's the professor of obstetrics and gynecology in Ibadan, and he looked at this and he found that amongst this group of women, they did a sort of a small survey or a big survey, but a specific questionnaire. Actually, stress incontinence was present when you asked the question, and urgent incontinence was only 1%. But it was interesting that we all believed that the urgent incontinence would be the biggest prevalent feature, but it wasn't. So this is another interesting study. So bringing out the fact that just because we think stress incontinence is less prevalent, it doesn't mean it doesn't exist. So the other group is really looking at the prolapses. So that's a bladder prolapse here. So you've got the womb, the bladder in the front, and the rectum. So the bladder's coming through the vagina there. And here you can see the rectum, so it's known as a rectocele. And the combination of both of these or one of these can impact on your bowel function, bladder function, sexual function. And often within the Black community, surgery is resisted. And this just shows you the uterine prolapse. But if you then look at prolapse in prevalence within the Black community, and this is a study from the US, you can see that actually Latina and white women had 4 to 5 times more risk of getting a symptomatic prolapse compared to African American women. And it's very interesting that actually when you had the symptoms and then assessed them, it was the Caucasian women who had a 1.4-fold increase of an objective prolapse. So prolapse seemed to be much more of a feature within the Caucasian group than within the other groups. And the question then comes into is there a racial difference in the collagen makeup that allows the ligaments and so on to suffer? So there's a whole disparity and you have to be aware of that. I'm just briefly mentioning FGM because now FGM is no longer a localized disease, but a global condition or a global cultural issue, and every society has been dealing with this. We did a recent webinar on this, and it was fascinating for me to learn how many centers in Europe specifically now have popped up looking after women with FGM complications. And this is just to show you that they are quite dramatic, particularly the long term, although the immediate ones we don't often see, but we do see all of those. So, healing issues, infections, abnormalities, sexual dysfunction, fistulas, and so on. So there's an awful lot of issues that need to be addressed within this group, and we know they come from predominantly sub-Saharan Africa and the Horn of Africa. So we have to be aware of this problem within our community. The complexities that we have to address in women's health is really that up until we started looking at it, many women post-childbearing were not looked after in the NHS because there was a tendency to focus on safeguarding of young children and young adults or adolescents, and then to focus on the obstetric issues. But there was no discussion about what happens after that. The other arena I worked in was fistulas, and it's a big problem in the developing world, as it were, or in the under-resourced setting, but it still happens here. So, you know, I looked at my figures recently, and in the last 7 years, we've done 36 fistulas. So that's quite a lot when you think that we're in the UK, albeit we do get referred cases from around the country, but that's still a large number. And perhaps this is my bugbear. It's chronic pelvic pain, often very much underplayed, ignored perhaps, and a lack of perception that this is a major issue. So there was a very interesting article. This was done by Christine Labuski, looking at the issues from a Caucasian to a Black issue. And she found that she's a sociologist. And what she found was that there is a perception by clinicians, particularly on genital sexual pain and so on, that suggests that actually if you have pain there, it might not be real pain, that there might be other issues going on in that person's life. So there's a stigmatization, there was discrimination by healthcare practitioners, there was a sort of a, you know, not assessing the patient. And so she was able to show that when she looked at all the sort of background and so on within the US in particular, she says it was very clear that the way clinicians couldn't speak about the pain meant that Black women and Latino women in particular did not mention it. So it's a question of really identifying our shortcomings in order to help your patient. And to sort of show this, I'm part of this guidelines committee. It's from the European Association of Urology. We produce an updated document every 2 years. And very interestingly, we've never looked at racial disparities in pain. And so this year, we're due to do the update for next year, 2021. So for the first time this year, we're looking at that and looking at how pain is reported and what specifics we should be looking at. So the epidemiology of pain needs to be revisited. So in summary, what I'd like to say about the issues about women's health is that they are the physical issues, which we can kind of understand, but there's a significant component of the social issues, particularly with the impact on relationships and dependency and so on. But what I found in particular amongst Black women with women's health issues is they tend to leave it for a very long time and usually come when they've really got to the end point. So by that time, the impact from a mental health perspective is significant. Now, I have looked predominantly at the quality of life of women with benign disorders, which is by far the majority of women that we would see with issues affecting them in health. But that does not mean, oops, I think I've missed the, sorry. That does not mean that we should not forget this. So the anemias, particularly sickle cell anemia, the cancers, we mustn't forget breast and cervical cancer, two big arenas, the access to care barriers, the social, financial, and the racial barriers, and then the implicit trust and belief. Because actually, if you do not take all those into account, by the time you've got a woman in front of you, you must bear in mind there's all these other background issues that you must be able to address, or at least leave the door open for dialogue and discussion. So in my opinion, in women's health, generally, it must be a multidisciplinary, holistic approach. You need to look at all the complexities. You must understand the religious, the cultural, and the social. So it shouldn't be just about the condition, because often that opportunity, and because of the various disparities, is perhaps the first time you'll get the opportunity to actually talk to somebody through all their medical problems and maybe pick up on a lot of other things which are hitherto not seen or ignored, perhaps. And I always finish with this, and I think it's good for us to remember it. And it's from Socrates. And I'll just read it. And this, he said, is the reason why the cure of many diseases is unknown to the physicians of Hellas. Hellas is the physicians of Athens, because they disregard the whole, which ought to be studied also. For the part can never be well unless the whole is well. And I think this is such an important statement. It's all very well if somebody comes to see you because they have fibroid uterus and infertility, but if you don't look at all the other factors around them and understand them and actually try and help multidisciplinary way, holistic way, then you often would have lost the opportunity to actually make that lasting difference. So when they come to you, that's the starting point of really getting people back on track with health and opening the doors. And bear in mind that disparities are not just at that episode, but they've been tracking from historically, and you need to prevent those disparities from being an issue in the future. Thank you.
Thank you so much, Ms. Elneil, for that really fascinating overview of issues affecting women, particularly around gynecology, and also for highlighting, as you quite rightly say, the holistic side of it in terms of their psychological, spiritual, and other and social health as well, and well-being. I've got a couple of questions for you personally, but I don't want to be the only person asking questions, guys. Remember last time I had advised you to always write down a question that you can then ask our speaker, okay? So I've got two questions. One, so it's really good as well that you were able to cite some research that included Black women as subjects in that. Over the course of your career, have you seen an increase of studies that have included Black and ethnic minority women to be studied? And secondly, how does that, it's good to, the studies will show the disparities and the differences, but how has that affected actual medical practice? What happens in a consulting room? What happens in a GP situation? Has it changed the approach that doctors have used when speaking to women, or is it still a case of, well, endometriosis is more likely to be a non-Black issue, or fibroids is more likely to be a Black issue? Are people changing their practice and approaches based on that?
So thanks, Michelle, for those questions. So over the years, I think two things have happened. One, more Black women have come to the fore, seeking address and redress. Still too quiet, still not, forcefully forthcoming. Really, still waiting until an issue arises, etc. But within the so particularly since the COVID epidemic has hit us, there has been a big drive in the role of what happens with
Sorry,
sorry, shall I wait?
So I've just muted everyone, but I can still hear a lot of noise there. Okay, yeah. Carry on, Susie.
Yeah, so I was just saying, so within the, since COVID has happened, there is a change in ethos, and I can see there people looking at how we're going to address all the disparities and bringing in the equality into that whole issue with regards to diversity and inclusivity. So there's, I know they're buzzwords, but actually it has impacted on how people approach things. So what the other thing is that I think a lot of people still believe fibroids are a Black issue, endometriosis is a white issue, pain is a more of a white issue, Black issue, it's usually an infection. There's still that happening the whole time. So I feel very strongly that the only way you can change that rhetoric is going to be more of us putting our foot forward and talking about it and raising issues and so on. So, a lot of the times when we are writing documents and so on, we're now bringing it in. So it's part of the mainstream guidelines literature. And it's not in a little subsection talking about diversity, inclusivity. No, bring it into the main body. Yes. So that's what we're doing with the guidelines on chronic pain, bringing that whole issue into the main body. So from that perspective, yes, there will be change, but it's not fast enough. And I can't. Sorry, Michelle. The second question you asked me, I was questioning.
I think you've answered it in terms of how is it changing actual practice and approaches. I'm really struggling to remember the name of a young doctor. I think he was at Tooting, and he was in the media just recently, like in the last 2 months or 3 months, because he's rewritten a kind of a guidance, and it's to do with some sort of dermatology. There's some illness with a dermatological sign that was more difficult to spot on darker skins than on white skin.
It might have been Addison's disease.
Sounds,
because it leaves markings on your knuckles.
Yes.
So it's hard to see it.
Yes. And so it was being missed with patients coming into A&E and Tooting, and he took it upon himself. He was in the evening news in London, talking about the fact that he's rewritten this guidance now to help white doctors to be able to spot this in people with darker skin. So so it's still a lot of work to be done, but it's good to see. Yes, I'm glad that you quoted studies that showed, at least Black participants in those trials. And my next question is, do we know why Black women are more likely to have fibroids or thickened endometriums, for example? You mentioned that. What is it? It's just, what is that? Genetic? Why is it different to somebody else?
So there is a racial. So for instance, if you look at Black women, particularly Black women from West African origin, have a higher risk even compared to other Black women. So if you look at that group, there's something genetically different or racially different. There are also factors associated with hormones, particularly progesterone receptors, and how progesterone receptors work in Black women. So for instance, a lot of Black women, if you put them on hormonal treatments, doesn't always work well with them. So there's something different in the way we metabolize things and how we do it. Now, the big issue is because you need to actually do the science to prove it. That is one of our biggest problems, getting very specific science for Black community or Asian community patients. This is not an easy thing to get, particularly the focus will be generic, hypertension, for instance, it's generic, everybody with hypertension, but actually if you do subgroups, you'll find, for instance, within Black males, they tend to have a sodium disorder. They almost all have a little bit of a sodium disorder. So actually, just putting them on antihypertensive isn't the answer. They often have to be on something else, like spironolactone or whatever. So it's all that sort of stuff. And we know what needs to be done, but it's making sure you can prove it needs to be done.
Yes.
So that's always our shortcoming.
Yeah, my goodness, lots of nuances there for different conditions and different ethnic groups and so on. Yeah, don't know how it can all be tackled in a 10-minute GP appointment for the GP to then work out where to refer a patient. But hopefully by the time they do get referred, they can meet someone like you who is able to unpack a lot of that. Okay, so those are my 2 questions, ladies and gentlemen. Do I see any hands raised for further questions? So remember, we're talking today, for those who came a bit late, it's about the self-care and our health, women's health, men's health. I see you, Loxley. So it's not so much that you're getting a lecture in gynecology. This is about raising your awareness of conditions and complaints that women have in terms of their gynecological health. And as you heard, Miss Elneil said that, we are not very energetic in terms of coming forward to seek the help that we need. And I think even when Black women come in and see a GP, there's a skill that needs to be developed even to have that conversation with the GP to ensure that you are actually getting the right care, questioning and asking things so as not to be automatically slotted into, well, it can't be this because I noticed that your skin is black. You know what I mean? It's probably not that. But it's learning that that conversation that you need to have with your GP, and to be confident, bold enough to actually ask the kind of questions that you need to ask. Loxley, you had a question?
Yeah. Thank you very much for that. And I found that extremely interesting. I was here making some notes. And although this is about raising awareness, is there any takeaway message from this? What is the message that you would like everyone to take away from this session?
I think it's the most important thing is, I think, do your homework before you go. So if you've got a problem, you've got a symptom, you've got a worry, do a little bit of homework about that condition. Find out a little bit more about how it affects not just you, but actually many of you, as it were, some background info. Have a really good directed history and go in, because I think one of the problems a lot of doctors don't cope very well with is that when a patient comes in and they are a little bit all over the place, so they then tend to just focus on one thing. I've heard it from trainees who will say to patients, give me your symptoms 1, 2, 3, which actually is impossible. So one, do your homework, make sure what your condition is, be ready to ask the questions, take an advocate with you, because actually the advocate can sit and listen and write notes and make questions. That really does help. If there's anybody who's even mildly related to the medical field, doesn't matter what it is, take them with you, speak to them, get some insight from them, because they'll often have extra knowledge and give you the base to go from. And that way we will all just improve our own education. And actually, if you go in as 2 as opposed to 1, you're usually stronger in the environment. And so, and I say that to all patients, but I think specifically with Black patients and ethnic minority, don't be afraid. Go in, go as a team, go in ready, and sit there and take notes and ask the right questions and ask the questions.
Yeah, absolutely. And don't be afraid as well to say that you're a health worker, you work in the NHS, so that automatically puts you on a stronger footing to manage that conversation. Okay, any other questions?
I saw something in the chat about holistic care in FGM, Michelle.
Okay.
And so somebody was asking, so we run a clinic, it's known as the Zahra Clinic, which means flower in Arabic, where we've got a midwife, we've got myself as a urogynecologist, we've got a psychologist, we've got access to pain services, physiotherapy, and so on. So the holistic approach to managing the complications is really about managing the whole woman and accepting. I mean, one of the things I was very keen on with FGM is that you don't focus just on the FGM, because there are lots of other things women have besides FGM. So let's look at the whole woman. So that's the way I look at it.
Okay. Just one more question here for you, and then we will move on because I'm conscious of time now. This question says, the BMJ recently highlighted that Black babies are less likely to die when cared for by Black doctors. Is the same true for Black adults?
The answer, unfortunately, is yes. And there are many studies showing this. And I think there's been a huge number of studies of maternity in the US, where it shows that Black women cared for by Black obstetricians and gynecologists would survive huge adverse events, whereas if they were not, they would succumb. So as you know, maternal mortality is really high amongst Black, particularly young Black women in the US. Many of them are unbooked. They are having babies in their late teens, early 20s, and suffer with preeclampsia and eclampsia. So a lot of them would just die, basically, because it was not really thought through about their risk. So yes, unfortunately, there is evidence to show that.
I just wonder, and this is a rhetorical question, whether the inverse is true as well. I don't know. Okay, so thank you so much, Mr. Elneil. I am sorry, just I think coming to the end of my day now, so and I've had my head in so many places for the day. Elneil, thank you so much, Susie, for that. And if you've got further questions, hopefully we'll have time at the end as well, so you can ask some more questions of her, pop them in the chat as well, and I will ask. Okay, so our next speaker is, bear with me, another consultant by the name of Jean McDonald. And I'm not sure whether Jean is actually in the room at the moment. I've not noticed her coming in. Jean, are you there? If so, can you identify yourself? No, maybe she's a bit delayed. Let me make sure she's not in the waiting room. No. Okay, so Jean is probably delayed. I don't know whether Pat, have you heard from her or anything? No.
No, I haven't.
Pardon?
I haven't heard from her,
Okay.
actually.
Okay.
I know she has a clinic
Jean...
this afternoon.
Right. Okay. So Jean McDonald was going to speak on men's health for us, and hopefully she'll still be able to make this event. But we all know how things run with these clinics sometimes. So I think we'll just get our next speaker on then, because she is here, Bridgette York, who is she's a criminal lawyer by background, but has become quite an active patient voice within the NHS. As an advocate, and has worked even with NICE developing guidance and so on. So Bridgette York is the founder of Fibroid Network International Support Group. She is a patient's advocate who speaks not only from personal experience, but from knowledge-based research. So she has worked on fibroid patient quality of life and patient safety as an advisor, Parliament Policy and Campaigns Officer, founder of the Fibroid Network. She's done some media liaison, stakeholder in heavy bleeding. Okay, so she's worked on developing guidelines for heavy bleeding, heavy menstrual bleeding. So quite a bit there really. And so she's about an advocate for informed choice, which I think comes back to that conversation I was mentioning between a patient and a doctor, so that that patient can get the best out of that discussion and then be able and supported to make an informed choice in terms of their care and treatment. Women's health advocate, evidence-based medicine researcher, qualitative research assistance to UK Parliament, cross-party groups. So again, another dynamic woman here who is doing above and beyond, as it were, her core job, supporting Black women's issues. I think this is wonderful. Don't you guys think this is wonderful? I'm not seeing you all. You're all hiding. You've all switched off your videos. But I think we should be heartened by this, because sometimes when it comes to race and race issues, we can begin to feel that we're alone and there's nobody fighting for us in any sphere apart from the obvious people like Diane Abbott, who's in the news or whatever. But actually, not just in this session, but in every dimension to do with our lives, there are unique and wonderful and dynamic individuals who are lobbying, who are advocating, who are working and being our voice and representing our voices at decision-making level nationally or regionally, right? So take heart, take heart. I'm always excited when I meet a new person who's doing that sort of thing. So without further ado, Bridgette, the floor is yours. Did you decide whether you're doing a slide presentation?
Yeah, I'm going to see if my screen can share.
Okay.
I'll just test it actually. Okay.
Also, while Bridgette is doing that, I also want to encourage each of you as individuals as well to actually do that, to step up yourselves and become active in some form of activism, because the more the merrier, really. There's still, even though there's so many activists out there, there's still a lot of work to be done, and we all need to step up and do our bit as well. Okay, so Bridgette, looks like you're there.
Can you see? You can see the screen.
I can see the screen. You just have to put it on your slideshow. Wonderful. That's fine.
Okay, so a bit about me. I found out when I was 25, just qualified as a solicitor in London, that I had fibroids. And this was a shock to me. I'd never heard of the condition before. I felt a lump in my tummy and it seemed to get bigger over time. And it was just over a year, suddenly there was like quite a quick growth. So I'm kind of wondering, what is this? Am I pregnant? Is it cancer? went to see my GP. My GP said, oh, it could just be your abdominal muscles, but I felt something was wrong. So eventually I managed to get an ultrasound, and they found at 25 a 10 centimeter fibroid, which is a benign tumor, right in my womb, and 3 smaller ones. So this was a shock to me. And at the time when I looked at any books I could find on it, it said if you had a 10 centimeter fibroid, it would, they'd do a hysterectomy, you know, because it might be cancer. And it was unusual at my age. After I'd done research over a number of years, I realized that actually it was very common in Black people. And in fact, it was more common in young Black women at a younger age to be symptomatic and have very large fibroids. That presents a problem because at the time, which was around 1995, at that time, the standard practice was you had a fibroid and about 80% of women, irrespective of race, would be given a hysterectomy. So if it happens to you when you're not even thinking about having children yet, it's a shock. And I felt that it couldn't be right because I found out it was a benign thing. It doesn't become cancerous. 99.97% of fibroids. So if you had a room of 400 people, you may have 3 people. There's a very small risk that it could be cancerous, even if it's big. Why are they taking your womb out? Why are they castrating people for that condition? And it bothered me, and I happened to be a researcher as a lawyer. And I basically went out and researched. There was no fibroid charities, support groups. There was no leaflets in the NHS about it, despite the fact that it affects at least 50% of women of any race in the UK. But up to...
Sorry, Bridgette, sorry
Yeah.
to interrupt you, but I keep hearing some kind of feedback in the background. It looks like everybody's mic is muted, but I don't know if other people are hearing it, but I am hearing it. So I don't know. Is it pretty quiet where you are, Bridgette?
I can't hear anything here.
In your environment, I mean, no?
Is it an echo on my side?
I think it might be because everybody is muted except you and me. But okay, just carry on then. Maybe we'll manage.
Okay.
Like right now I can hear it now that we're quiet.
Ah, okay.
Okay.
Okay, so basically, what I did, I watched a program, and Oprah Winfrey had done a program on fibroids, and this is around 2000-ish, and she was saying it's quite uncommon. There isn't any research on it, and I was thinking, well, we've got nothing in the UK, and I decided to set up a group because I was hoping if we shared information, if I found others and tried to work out how they managed to get over it without having their wombs removed, then that might be something I might have an avenue out of it. I then set up the charity. I was approached by the members of parliament because it's such a common problem. It affects people from all sort of backgrounds. So you'll have MPs, you'll have nurses, you'll have doctors, you'll have everyone else who's not in the NHS. There are many people affected by it, and there was no one doing anything about it. So eventually I set up the charity. I was given a parliamentary reception on it. They actually supported me in setting up the first guideline on heavy menstrual bleeding, incorporating fibroids. How's the sound? Is it okay?
I can still hear it, but I don't know whether it's bothering others. Do carry on.
Okay. So I then set up the charity and worked on the guideline from 2004 to 2007, which was to actually bring in alternatives to hysterectomy. that has actually linked into a few other issues that have come up now. There was a problem with data capture, and the data capture issue is, what is the long-term effects of these treatments? We're having the same problems now with COVID-19. What happened to the women who had a specific treatment on the NHS? What was their recovery? Did their quality of life improve? And we're finding that problem here now with the statistics with Black and ethnic minorities. No one had noticed that there was all these issues with the Black community, such as things like you have 21% of the staff that are BME, but 63% of the healthcare who died were BME, AME. 20% of the nursing staff is BME, but 64% of nurses who died were BAME. And 44% of general medical staff and doctors were BME, but you have 95% of the doctors who died were BAME. But no one seemed to pick up on that at the beginning. And one of the issues with COVID-19 actually illustrates a bigger problem in the NHS, and that's that when they capture data, they only show up to 6 weeks after discharge from the hospital. So if you go in, you have COVID-19 and then you're sent home, unless you go back in within 6 weeks, it doesn't capture everything that happens next. So it could be you go home, you might have just, you didn't die on a ventilator or anything. You go home and then you end up, you die at home at 2 months, it would not show. So a lot of deaths that happen were not captured, and that happens in the Black race and in other races as well. And if people were discharged, they may have gone on long off sick, and then it doesn't show anymore on the hospital's episode statistics. That's been a problem for gynecology, as well as every other area of health. So it means that it looks like, okay, there was a successful episode. You know, there wasn't a death in that episode, but then later, that person may have come in 2 months later, gone back on a ventilator and then died. But on the hospital episode statistics, it might show as 2 events, and it looks like 2 people, not the same person. You get that in gynecology, where you're having a minimal treatment. Say if you went in for the removal of fibroids from the womb, and you had a minimal surgery and they took out some of the fibroids and you went home, you could come back 6 months' time with the same symptoms because they didn't remove all the fibroids. And it doesn't look as though the previous surgery was not a success because they see somebody going home. And the problem with data capture is going across all of the studies that they're doing on Black and ethnic minorities. It doesn't capture those kind of readmissions. It also doesn't capture the what treatments you're receiving. So you might have a main treatment that's on, but it doesn't show all of the other health issues that you might have that you're receiving medications for. And sometimes the combination of treatments can actually cause more damage and end up with long COVID damage. Whereas on the statistics, it looks like the first thing that you came in with, like, which may be a respiratory problem, might be the issue, but you might be readmitted a few months later with a heart condition, and that may not go down as a COVID entry. So basically, you have a big problem with you can't even artificially sort of use artificial intelligence to work out what is going on in NHS data. Because it only picks up the first diagnosis of what you go and tell your doctor you have. And that will continue to be a problem until they actually get round to capturing more data, and that comes down to patients. Patients need to feed back all of their issues when they come out of hospital, any new conditions. There's a service called the MHRA, which is a service where you can report problems with medications and devices. That isn't used enough, and a lot of health advocates weren't even aware of it. We have other issues in gynecology as well, such as if you remember historically, there was a doctor who's the godfather of gynecology called Marion Sims. They call him that because he was the one who developed things like hysterectomy, dealing with hysterectomies, dealing with fistulas from prolapses. But what he did was he experimented on Black women who were slaves, and he kept repeating operations on them without anesthetic. That kind of data is also not captured. So you may have somebody having an episode, they may have a complication of pain. They don't ask about that. They just ask whether the condition, so maybe she had heavy menstrual bleeding and they treated it, is that improved? And you miss out on all the other issues that patient is having. So we're still having those issues with Marion Sims and experimenting on patients without anesthetic. That is still happening today, and that's quite awful. But again, it comes from having a service which doesn't capture all the problems that women are facing. Another issue, go back to it, I'm going to run back. Okay, another issue is problems with diagnosis. That was another issue with COVID-19 as well. They now believe that people were going into hospitals in December with COVID-19 symptoms, but they were diagnosing it as other things. So it may have been diagnosed as flu or other heart conditions, but they were showing symptoms of COVID-19. And now when they've gone back and looked at some pathology, they've actually found that they had COVID-19 from then. Same issues happen with gynecology. Somebody comes in with menstrual pain, or they think it's menstrual pain, but in fact, it could be a number of different things, pelvic problems, could be appendicitis, it could be cyst on ovaries, it could be kidney stones, it could be actual dysmenorrhea, which is pain during the menstrual cycle, it could be irritable bowel syndrome. And so women find it difficult to describe their anatomy. We're not given education in schools. Same problems for men with prostate issues. They may not identify problems soon enough. So it's important that there are support groups for different issues, even on Facebook and different areas. A lot of people are now speaking about their symptoms and putting together a list of symptoms. And then the message can go out, these are the symptoms to look out for, because often the ones that are in the system or built into these apps and things are not correct, because they don't have all of the symptoms that are linked to a problem, or even a problem with a side effect of a drug. It doesn't pick it up as that, it will pick it up as a new condition. And then the patient might find that they're getting treatment for more than one condition, when in fact the condition came from a side effect from treating the first condition. Another very interesting study that's recently come out in relation to that is a new study on obesity, which literally came out in the last few days. And it found that in postmenopausal women, the risk of obesity is actually increased by certain medications. So somebody could be on gabapentin, which is a pain medicine for other things, like they may have some pain in their stomach, or there's been an issue recently called mesh, where people receive prolapse treatment and then ended up with chronic pain. A lot of women were put on things like gabapentin. Some of them were on antidepressants, and some of them were on a whole range of drugs for different issues. But they found that women who were on those drugs and some steroids actually developed obesity, and the cause of the obesity was not their lack of physical activity or their diet. It was actually the drugs, and it was a side effect of the drugs. And a lot of people have been stigmatized about obesity, and people assume it's because, you know, they've got poor diet and stuff, but they didn't really look at these issues. But now they're starting to look at pharmacotherapy. So you have an issue of, in the past, when they looked at risk factors, they looked at social and economic things, your race, but they didn't look at what types of drugs you were using and had access to, or specifying right down to the detail exactly where is the pain, what are you taking for the pain, and what are your other conditions, and are the conditions related to the treatment you're receiving. One of the other areas where that came up in gynecology was Esmaya, which was a drug that was given as a treatment for all women, as first-line treatment for heavy menstrual bleeding. That was on the guidelines, on later guidelines after my one, but they then later find out that it caused liver damage. But those patients, all they would have known was they had pain in the upper area, but they would probably have described it as menstrual pain. And it didn't come up, it wasn't picked up in the UK, it was picked up in France, and they had 51 cases of liver failure. It was put on a review here, but people weren't notified of the issues. It's really important for everyone, if you're put on a drug, don't just assume just because the doctor says take this drug, it's okay. Always read the instructions on it, because sometimes these instructions were on there. Another area where there's a difference between Black women and white women is the size of the fibroids when they present. In white women, it appears that in younger women, they may have smaller fibroids which aren't symptomatic, and about 40% of them aren't. So with older women or with young Black women, they may have very large fibroids like this, which wouldn't respond to drugs, but many women are put on drugs. They also push a thing called Mirena. Sometimes for some women it's great and it stops heavy bleeding, but they don't actually recommend that it's used for women who have fibroids. And this area is the womb here, but the cavity. If you try and put a Mirena device in there, you may actually cause more damage, and people have ended up with perforated wounds. So there are differences in when these things should be given and who they should be given to. Another issue that's not talked about much, but it goes back to the 1940s, was that some women are actually developing diseases as a result of medications that were given to their mothers or to them during their lifetime. And what was quite interesting, there was a drug that was given as a miscarriage, to prevent miscarriages many years ago. And it was given in the UK, in America, they think at least 10 million people were exposed. They then discovered over the years that the women who were given these drugs were more likely to develop fibroids. And they did very big studies. There was like thousands of women in them. And it was one of the #1 risk factors for developing fibroids and endometriosis. But what we find is when doctors talk about fibroids and endometriosis, they don't mention it. They don't mention that their forefathers may have given a drug that actually increased the risk of these diseases. It may be embarrassment. It may be. I mean, it's not something, you know, that they're particularly enamored about, but they do actually monitor it in some areas. We're not sure how much it's monitored in the UK, but that's one of the reasons why it develops. And then there's another area which pulls off of that, which affects men and women, is the study of the effect of chemicals in the environment. And the environment can mean even, you know, ones that you're prescribed, to increase the risk of drugs later, of diseases later in life. And that,
Bridgette, just
yeah.
5 more minutes for you,
Yeah,
5 more
okay.
minutes.
Okay, so that study now is called Exposome, and this is something that everyone should be looking at, men, women. It affects children, but it looks at not just your social and economic and your race. It looks at everything, every exposure, pollution, the drugs you take, because some drugs can increase the risk of cancers. And prostate cancer. They're called endocrine disruptors, most of them, but they can be in your home environment, it could be in your work environment, you're exposed. And this is the area where they're actually making more progress in research. So all the areas where they weren't sure what caused it, when they add in the fact that of chemicals in the environment, including in prescribed drugs, which were always left out, they're now finding that on top of things like diet, physical activity, sleep, social, smoking, and your genes actually play a much smaller part than actually your lifetime exposures. And because of that, most of the government health bodies in America, in the UK, were very slow to pick up on it. But in other countries and across Europe, the new focus on research is Exposome. So if anyone is doing any research on their health, on any area of the body, I'd recommend looking at this area, because you're going to find that you're going to have some answers to questions about why some diseases are happening and why they're more prevalent in the Black community. Like, they've also found that our hair and beauty products can actually affect our fertility, because some of the chemicals are so toxic, it can actually cause infertility. So that
Thank
is.
you, Bridgette. We're going to have to, get you to conclude now, please, because we've got another speaker.
Basically, I'd thank you so much for having me, and I would suggest that everybody takes part in looking up the research. Sometimes you can't find all the information on the main websites, but we're now finding that doctors are catching up with our research and seeing their own. They're not even aware of their colleagues' research. And if you can put it together in one place, they will find the research, and everybody should be collaborating together.
Thank you very much indeed, Bridgette, for that overview of the influence of race on treatments. I wonder whether you can just give us a very brief pointer around the role of race in terms of accessing care. And as Loxley asked the former presenter, what would be your takeaway message from this that you want us to take away from what you shared?
I think it's really important. Oh, sorry.
Yeah, carry on.
I think it's really important that you partner with your healthcare provider. If you find research that may be helpful, bring it to them. You need to tell them if you're having a problem with an issue. Sometimes the treatment you think you need may not be the most appropriate, and it's really important to join groups, try and find out as much about other people's experience with that particular treatment before you make a decision, and do as much research as you can, because often healthcare services research is behind. And also ask for patient information leaflets. A lot of hospitals are not providing them. There was a survey done by another group which found that about 70% had no leaflet at all. If you don't ask for it, they won't feel under pressure to provide it. So keep asking for information leaflets. Even make a complaint about it if you don't get it, because you need to know the risks and benefits of each of the treatments.
Right. Thank you. I think the key thing then is really just to remind us all that, you know, our health care, even though we're going to see a doctor or a nurse or some other clinician about it, is really our responsibility. And so we need to become very active in our healthcare treatment and in the process around our healthcare. So it is really up to us to look at, if you're prescribed something, to get familiar with what you've been prescribed. And there's so much information that's easily accessible online, or even in the leaflet that comes with the medication itself. So it will list some of the side effects that Bridgette alluded to as well. Get to know your own condition, get to know what the treatments are, become an educated expert patient on your particular condition, and take control, really become activated as a patient so that you can build that. And in fact, once you start to interact with your medical and your clinical staff as that person who has, you know, built their confidence and the knowledge around their illness and the treatments around their illness, you actually get a lot more out of your clinical teams, to be honest with you. And then you can enter into that sort of partnership relationship, as Bridgette was mentioning. Thanks so much, Bridgette.
And I'd just like to say as well, I actually did have a success at the end of my journey, and I went on to have an open myomectomy, which taking out the fibroids. I then went on to have twins, healthy twins, at 40, when I actually got round to having children. So it is possible to go against whatever the healthcare had said at the time. Do your research, and you will be, in many cases, successful and get the goal that you want from treatment.
Terrific. So you've got a very glowing comment here. Bridgette, I could listen to you all evening. First time that I have ever heard of exposome, worth a lot more personal research. Thank you. This is from Jacqueline Jackson. Thank you so much. Okay, so we only have about, I don't know, 35 minutes or so, and we've got our third speaker in the room. She is also a consultant, Miss Jean McDonald. Thank you very much for joining us. So I'll just introduce you based on the bio that I was sent. So Ms. Jean McDonald is an esteemed urologist with 23 years experience as senior urologist at North Middlesex University Hospital. Ms. McDonald consults on a range of conditions, including female urology, bladder infections, kidney stones, urinary incontinence, and general urology. After initially graduating from the University of the West Indies, I did read that earlier and I thought, ooh, wonderful, the West Indies. Ms. McDonald spent a further 9 years in the Bahamas in a range of surgical roles before moving to London in 1982. She became a fellow of the Royal College of Surgeons of Edinburgh that year, and subsequently pursued specialist training in general surgery and urology, gaining her diploma in urology at the Institute of Urology at UCL in 1990. She was appointed consultant urologist at North Middlesex University Hospital in 1995. She has served in many capacities at that hospital, including clinical lead, deputy chair of the Medicines Management Committee, and surgical tutor. She has established a number of innovative programs, including nurse-led urodynamics, prostate clinics, erectile dysfunction clinics, and nurse-led cystoscopy units. So it's such a pleasure. I'm thrilled that she has set up so many services that are nurse-led. I myself was the nurse of a nurse-led clinic at UCLH for almost 10 years. So it's good to when a consultant backs the nurse within their teams to develop their professional practice and leadership and clinical range, really. So I just, without further ado, want to welcome Jean McDonald. The floor is yours.
Okay, can you hear me?
We can hear you, yes.
Yeah, thank you very much. Unfortunately, I'm not as prepared as I should be. I've been up operating till 2:30 in the morning, early this morning, and
wow.
I'm just at a clinic and was just about to go down to see the patient. But anyhow, I'm glad to participate in this. As a urologist, what I actually do, I look after men and women, but a lot of gentlemen. And the problem with the topic we're talking about today, it's Black men and prostate cancer, right? That is quite a topical subject because, as you know, the incidence of prostate cancer in the Black male population is quite high. Unfortunately, what tends to happen, it tends to be diagnosed late. And one of the reasons is that a lot of gentlemen do not like having a digital rectal examination. In other words, they have to come to the surgery to see us, and they have a little examination where we put a finger up into the bottom and feel the prostate. This is to feel if it's hard or if there's any abnormality there. And that tends to put a lot of gentlemen off. Anyhow, what I've found in talks that I've given, if you stimulate and tell the ladies to make sure that they look after their gentlemen, then you find that the gentlemen will actually come. And they're willing to come eventually once they're convinced. Now, it's important with regard to prostate cancer that it's diagnosed early, because if it's diagnosed early, we can treat it. When it's diagnosed late, and you can have lots of problems then with problems walking because you have fractures, pathological fractures of the spine, etc. It's very, very difficult then to actually treat it. So it's important. We have lots of different ways of diagnosing prostate cancer. As I said, we do a rectal examination, but now we have MRI. MRI is a test that someone goes in. It's like a CT scan where you go through something like a column. But what happens is that it's very noisy, the MRI. And it can actually show if there are any particular areas in the prostate that need to be biopsied. In other words, anything that looks abnormal. And if that is so, then what we'll do is we'll actually have a biopsy, and then that will actually tell us what sort of cancer there is, if there is, and how we should best treat it. So from the in the Black population, it's important, and that's the message that I'd like to say today, that we really should come in early, get our gentlemen to come in early so that they can be diagnosed early if they have prostate cancer. The other thing about prostate cancer is that it runs in the family. So if you have one relative, father, grandfather, uncle, or brother who has prostate cancer, it's important to get checked, because the familial prostate cancer occurs at a younger age than in the regular older population. Now, another thing that happens as patients get a bit older, as gentlemen get a bit older, the prostate gland, which is this gland which is near where the bladder is, it gets enlarged and prevents you emptying the bladder properly. And what happens is that you can actually not be able, you find that you're not able to actually pass urine. It doesn't mean that you have prostate cancer. That could just be because you're getting a bit older. And then you find that you are passing urine frequently because the bladder might be overfilled. It's taking longer for you to pass urine. And these are problems that we can actually deal with. So it's important to come along. Those are the main things in terms of gentlemen. I see a lot of ladies who have problems with recurrent urinary tract infections. That is also a problem that happens both in the Black community and the white community. Lots of patients who keep on going to their GPs because they keep on having these infections in the urine. And they may have about 3 infections over a 6-month period. They go to the GP, they're given antibiotics, and it can be quite debilitating having all these infections, going to the toilet quite frequently. Sometimes the other thing is that they may have blood in the urine. Now, another thing that we have in urology is blood in the pee. And if you have blood in the pee, it's very important that you see a urologist, because that could mean that you could have a cancer in the bladder. And that occurs a lot in patients who smoke. And unfortunately, we find a lot of patients, they smoke for a very long time and they get blood in the urine, and then they have a bladder cancer that we have to treat. So different things I've touched on: prostate cancer in gentlemen, recurrent urinary tract infections in ladies, ordinary enlargement of the prostate, which occurs in gentlemen as they get a bit older. And that's another thing, because they may be scared to come to see the doctor, gentlemen, because even though they may not have prostate cancer, they're just having benign enlargement, they're worried it may be cancer. So these are some of the things that occur in our Black population that we need to be aware of. I don't know, Madam Moderator, if there's anything that you'd like me as well to speak about in particular.
Okay, yes. So we have contextualized the talk from yourself, from Bridgette, from Susie Elneil, in terms of our own healthcare as healthcare workers, and coming forward when we need to come forward if we've got symptoms of anything. Are you finding that in your practice that people are coming perhaps late with advanced conditions, whether it's incontinence or otherwise, particularly from Black and Asian and minority ethnic backgrounds? Are you seeing a difference between that group of patients and white patients in terms of how early or late they actually end up in your service?
Right. With prostate cancer, some years ago, we did find that a lot of Black patients came in to see us at quite a later stage in their disease. But I think the message is going across now. And I think with social media that people are more aware of, prostate cancer, because there've been quite a few celebrities. I mean, Nelson Mandela had prostate cancer, quite a lot of people. So people have been made aware, Colin Powell, so they're sort of saying, okay, fine, we should come forward and see exactly what's happening instead of waiting until it's quite late. Because unfortunately in urology, these are not things that people talk about. If they're incontinent, they don't really talk about it. They don't want to let everyone know that this is actually happening.
Yeah, absolutely. It's a difficult thing to discuss, but necessary to discuss, because if you come earlier, there's likely to be treatment that would be more effective.
Exactly. And that's what we want, patients to come early. We can then do an MRI, diagnose and treat.
Yes. Okay.
And you get good results from that.
There's a question in the chat. Can you examine at home like a woman who examines their breast? So I suppose in terms of prostate, is it possible
that
to do?
That wouldn't be possible. Right, because it would be a finger up the back passage to actually feel the prostate. So it wouldn't be something like a woman examining the breast. So in other words, could go to the GP, and of course there's a blood test that you can have done. And what we're actually saying is that if you actually go to your GP and you're over, say you're a gentleman aged about 50, you have a family history of prostate cancer, you can go to the GP and say, can I have a PSA test? Right? And then their age-related PSA values that the GP has. So in other words, you can have a higher PSA if you're older, but if you're much younger and your PSA is a a certain value, then that is more important, and that should trigger a visit to the urology department, and the GP would send you on this 2-week wait scheme where you would be fast tracked. And then when we see you in the clinic, we would do a rectal examination, and then we do an MRI on you, and then, you know, be able to tell you whether or not there's something significant there that you need treatment for.
Yes, thank you. And just there are several more questions that have appeared in the comment box, but I wanted to know, it was interesting to hear you say that it runs in families. And so there's a gene that's been isolated for prostate cancer, is there?
Yes, there have been quite a few sort of genes and different ones that, you know, keep coming up because there is a familial gene. There definitely is.
Yeah.
And unfortunately, people with that gene tend to have prostate cancer at a much younger age.
Sure. Okay.
And unfortunately, tends to be more aggressive as well.
Okay. Someone here is saying that GPs are reluctant to offer testing for 50-year-olds with a family history. How do we overcome this barrier? Presuming that we're talking about prostate testing.
Yes, I presume that. It's important because you have to go to the GP, because if you have a family history, I think the GPs are more aware of this now. And you know, they send lots of patients to our hospital, you know, with a PSA which is just over the borderline for that particular age. So they are, you know, being aware. And if your GP doesn't want to do that, I mean, you have to persist and say there is a family history of prostate cancer, and I would like to have a PSA test.
Yes, okay. And someone's asked here, are there any symptoms? You did mention some already, but if you wouldn't mind just recapping what they are.
Sure. Now, there are symptoms of just an enlarged prostate, which is somebody who is an older person. Say it can start in the 60s to the 70s and going up to the 80s, where just getting older, your prostate gets enlarged. And generally in Black patients, they tend to get really enlarged, big prostates. And what happens when it's benign, you get problems passing your urine. And usually you have to wait before you pass urine. When you're passing urine, it takes a long time for you to pass it, and the stream is not as good as it used to be. And afterwards, you may have dribbling afterwards. And then inevitably, if you do nothing about it, what can happen? You can go into retention of urine, where you're not able to pass urine at all. And then you have to be brought into hospital and have a tube put in, which is called a catheter. Right? That is benign prostatic enlargement. With prostate cancer, you might have no symptoms at all. So you might have nothing at all. All that happens is you've done a PSA test, it's enlarged, the PSA is high, and the GP has done a rectal examination, and the prostate feels abnormal.
Well, that's really interesting and scary, because you would assume that, you know, with cancer there, the prostate will have a response and become enlarged or something like that, but that's
not necessarily. That's the thing about it. So you might have nothing at all, no problems at all, and just routine testing. I know in the States, what happens is after the age of 40, they're actually doing routine PSA testing in the Black population.
Okay, so there's a question here. What are your thoughts on ball moss in the treatment of prostate cancer?
On what?
Ball moss, BALLMOSS, in the treatment of prostate cancer. I don't know, Lisa, if you can expand on that.
That sounds like a herbal thing or something. I don't know.
Quite possibly, yes, something alternative. I don't know whether Susie Elneil is still in there, because what I've just occurred to me is that we didn't touch on menopause at all. We only heard about the premenopausal, by and large, premenopausal complaints that women have. It would be good to have something said about menopause. I don't know whether Jean McDonald, you'll be able to as a urologist. I imagine so. And whether Susie Elneil is still in the audience, I don't know. But it would have been good, you know, because I don't mind saying, you know, I'm in the perimenopausal phase. But you're just riding through it as best you can with the flushes and the sweats and the general symptoms, really.
The gynecologist would have to be the person that speaks about that.
Yes. So I don't know whether she's still here or not.
I think she's already left, actually.
Oh, she's already left. Oh, that's a
Yeah.
pity I didn't grab it. It's just
She had to
recent,
leave.
just now occurred to me.
Mhm.
Okay, so are there any further questions for, okay, so here we are. Some forms of HRT are not helpful for fibroids. Okay, so unfortunately, we've lost our gynecologists, ladies and gentlemen, but I'm not sure how we will deal with some of these things, but there's comments now about fibroids and all sorts of things, but sadly, Susie's gone. Do we have any questions for Miss McDonald about urinary issues, prostate issues, pelvic floor issues, and the like? I think the clear guidance here, and it's good to hear that it's getting better, because it's something like 1 in 4 Black men will develop prostate cancer. Isn't that the statistic?
Definitely, yes.
Yeah,
And
1 in 4. That's a big number, big number. And it's interesting to see that suddenly the whole chat was lit with women asking about prostate. So clearly, as you were saying from the start,
this is what we find, and
these ladies have to take care of their gentlemen.
Yes, definitely, without a doubt. And they're usually the driving force that get the gentlemen to actually come in.
Yes,
Because
yes, absolutely.
they might be getting up at night and seeing exactly, and they're saying we need to get something done about it.
Yeah. Is there a systematic recall screening program for men around prostate, or is it something they just have to ask for every year?
I don't know of any sort of screening programs here at the moment, but as I said, it falls within the category of the 2-week wait. So if the PSA is above that level, you should be referred and be seen within 2 weeks in a urologist.
So we should, so the message then for the listeners is that at what age should you start asking for this per rectal test and a PSA? At what age in general should men do that?
Well, okay, if you're Black, I would say from you're about 50.
Right? Okay.
The history of prostate cancer in the family could even be a bit earlier.
Okay. All right. Lovely. So it's up to us or for the men really to go and initiate this process, ladies. It's not like cervical screening where you get your letter every 3 years or the breast screening program or whatever it is. The guys have to go and ask for the test. So just be mindful of that. Don't wait for a letter to turn up, basically. Do you think that the actual exam deters men from being tested?
I think so. And in the Black community, I know sort of in Jamaica, I'll tell you, one of my colleagues who was female, what happened is that she had a clinic at the University of the West Indies, and there were lots of gentlemen there. And she started her clinic and she started calling them, and nobody was coming in, and they all left just because there was a woman who was actually doing the clinic, you see.
Oh, wow.
So there's a lot that has to be said about this. But I think more and more they're realizing that ladies are quite gentle and, we look after you. So it's all right. And, if we have to do this examination. But, there is this thing in our culture saying that if someone puts, a finger there, it may sort of trigger other things.
That's sort of almost a taboo area in some cultures, isn't it? An area that no conversation area.
Exactly. No go, no.
Absolutely. But, it's so important still to overcome the cultural barrier, isn't it? And also it's interesting because my background is in gynecology as well. And of course, it's quite standard to accommodate female patients preferring female clinicians, and we try to set that up as far as possible. But I never even considered that men would probably, some of them would be more comfortable with a male doctor.
Of
so
course.
there you go. You've broken down a stereotype in my own mind. Wonderful. Can I ask this question? What are the things a woman needs if her ovaries are removed but not able to take HRT? Okay, so again, that question, Patsy, would have been for Susie Elneil. And if you are, just from my, have you spoken with your GP? That's what I'm going to suggest, is ask your GP, because there are alternatives to HRT. that some of them are more like alternative remedies and the like, but I couldn't tell you. And sorry, Susie has gone. So, all right, she says that they're not very helpful. Yes, I'm sorry about that. Sometimes one has to just ride through the menopausal symptoms, because if you take anything, when you stop taking it, chances are all of the symptoms will come back anyway. And that's the case with HRT. All it does is kind of pause the symptoms for the time that you're on it. But again, I can't give you that. I can't advise you on that. I'm really sorry. Any further questions for the lovely Jacqueline, sorry, the lovely Jean McDonald here. So that was somebody else in there called Jacqueline. But we're getting some very good reviews really about the speakers this evening. So let me read that out. Excellent speakers and advice. The speakers this evening need to be on national TV. The messages that they have all shared need to be shared far and wide. Patton Loxley, contact Lorraine on Good Morning Britain. What about Piers Morgan? Nobody wants these speakers to go on to the Piers Morgan show. Well, I've got something in mind, because I'm from a nursing background, and I'm thinking perhaps what needs to happen is these sessions for specific health issues is probably something we need to be doing really for our community, because there's so much going on now since the COVID effect, and everybody being on Zoom and facilitating all sorts of talks around health issues as well, particularly mental health and well-being and the like. But it will be good to hear some of this stuff around physical health as well. There's a new message here. How do we increase the number of Black consultants in London, given the BME make up 44% of Londoners, to ensure we have good health outcomes? That's a great question, Lisa.
It's something that's being addressed at the moment, because of course with BAME, it has been, brought to the fore how much, for example, in nurses, you have so many nurses and how many are actually in the higher echelons, and similarly with BAME doctors as well. They make up a great proportion of the population, but how many of them are actually in consultant roles. So it is something being addressed, and I'm sure I saw something from the British Medical Association that they're going to look into this and see what can be done.
Great, lovely. And then the next one is, do you feel that prostate screening should be introduced for men as a national program, I'm assuming?
It's difficult. They have had screening programs. They had a big Scandinavian trial where they screened thousands of men. And the result of this, hundreds of, thousands, they sort of found that the take-up sort of in people who did have symptoms, etc., to sort of make a big difference, it would cost too much. You see, in an actual a setting where people are not paying, you have to make sure when they're doing these sort of budgets to decide what they need to spend money on. You see what I mean? And then the powers that be and the people who look after healthcare planners, etc., they then have to look and see, if we screen so many hundred men, how many prostate cancers would we? Now, you remember, this screening is not happening in the Black population, because if it was done in Scandinavia, etc., you see. So the thing about it is that we find a lot of our population, they're not willing to go into sort of studies, etc., and all that, because of various historical sort of issues, and so we don't know, for example, that we have the PSA values, which is that sort of blood test, PSA values, but those are for Caucasian men, because there hasn't been sort of a big study in Black people, because the values might be totally different. You see what I mean?
Yeah, that's
right.
Possible.
And
yeah, sure.
what we have to be doing is extrapolating from studies that are done, you know, to say, okay, fine, this is one size fits all.
Yeah. Wow.
So we really need to have more studies done, especially in sort of some of the developing countries, right? You know, with predominant Black populations, and you'll be able to say, okay, in the Black population, this value is okay because, you know, that's the things that happen.
So as a marker, does PSA produce a lot of false negatives?
It's the best that we actually have. It's not taken by itself, because what happens is that we take the PSA value, what happens when we actually examine the patient as well, and of course, if there's an MRI. So it's not just sort of, okay, there are other things like if there's an inflammation in the prostate in younger men, and there's also the problem if you're not passing urine properly, the PSA can go up, because this is a product that's sort of made by the prostate. So inflammation, retention, if you just ejaculated, all of these things can put the PSA up. So, you know, it's whether or not you take it at this particular time, and then when you do it, say 3 months later, it's going up. So you have a serial sort of curve and see that it actually is going up to be able to say, yes, this is significant.
Are you seeing a lot of Black men coming forward around erectile dysfunction? I think I saw that as one of your areas of practice.
Right. Yes, we do. We do have, you know, they're actually coming forward, and it's very, very important, because some of the medications for patients with prostate cancer cause erectile dysfunction. And some of the patients you might have, you know, this is very important. So they will not even want to take the medications for prostate cancer because of the side effect of erectile dysfunction.
Okay. I'm just going to ask you one more question, Doctor. Clearly, this is a topic of great interest to the audience. What is the name of the prostate cancer gene, and what is the criteria for testing? Are they doing genetic testing? Are they actually doing genetic tests for these families, or it's just based on family history?
Yes, if there is a familial incidence, there's some specialist labs that are looking at the genomes, right? I can't tell you a lot about it because we don't have one, you know, this is sort of highly specialized. But if there is a history of familial prostate cancer, we can send you to the specialist centers that are actually doing that testing. And then they think there are different sort of problems with different sort of genes. So as a result of that, it's not just one gene, right? So the different combinations, and that's sort of something that's, you know, quite, how do I put, you know, quite, well, what do I say? It's actually something that's, you know, just for the specialist centers and not for just the ordinary sort of urology.
Urology, sure. Okay. Lovely. Thank you so much for that. Very informative, very insightful. Thank you for everything that you shared. You got lots of interaction on this topic, which is wonderful. And from women as well, which is interesting.
Which is very good.
So thank you so much.
A pleasure.
Ms. McDonald.
As I said, sorry.
This is at the end of your day. You've been up all night in theater, and you had your clinics to run, and you still came and shared so much with us. So we are very, very grateful indeed. Thank you.
Yes, you're welcome.
So I will now ask Loxley and Pat if they want to say any parting words as we begin to wind down this session. And, you know, in general, I would love to hear people's views. If you want to put in the comment, you know, we don't have an evaluation form here, but I think one is being created that will be sent round all of the subjects. But if you can put some comments in there, what you gained, how you felt over this Black History Month with the programs that Loxley and Pat have put on here for you, because it would help us to know where, sorry, I'm trying to double task here, whether they've kind of hit the nail on the head really or not, or what you'd like to see in any future Black History Month events, or even on an ongoing basis, you know? Do you want this to all stop at the end of October? Or do you want to see more activity going forward, whether it's on a quarterly basis or a monthly basis or something? You know, what are your thoughts? I'm trying to unpin Miss McDonald here, but without much luck.
To unpin me?
Yes, because I think I've enlarged you across the whole thing. So I'm trying to
see. Yes, let me see.
Yes, as people, are you guys, any thoughts? So I think the focus has been really good in that. Okay, I think it's fine now from my screen anyway. It's fine.
Okay.
We've all gone back to the grid. This is great. It's so important to hear. Oh, look, somebody's comment. I just lost it. So, you know, the first session was about your experience of, you know, working in the COVID lockdown and what it was like for you as BAME staff, as Black staff. And you had Joan and Paulette there. And then the next one was about, you know, a broader session on equalities nationally and within the union and the like. And this session was on physical health, issues related to men's health, women's health. And what's the fourth one, Pat? Is that the one that's the...
This is the fourth one. You missed out mental health and well-being,
Of
which
course,
you did.
how could I? My own session, yeah.
Your own session.
Thank you. So yes, there was one on mental health as well and resilience and well-being.
Yeah.
So we did mind, we did body, we did experience, soul. So experience of working in the COVID, as well as the session with Patrick Vernon. And I think coming up, there is one on that's more entertainment focused, am I right? And business and highlighting business. So that's combined into one session, or is that two separate sessions?
That's one session on the 30th.
One session on the 30th, yeah. On the 30th.
Exactly the same link, the same time.
Yeah, same link, same time on the 30th. And we have people like, what's going on with me? David Nita.
Yeah.
I was actually going to ask you whether we could have someone else as well to perform a piece of music, actually, but I'll speak with you offline about that.
Oh,
so
that's
what
great.
somebody here is saying, I would like to see more road shows featuring Black consultants. It is definitely much easier communicating with people who share the same background and culture. We hear you, Lisa. Then I'm so Patsy saying, I'm so appreciative of seeing so much of my people in such great positions and titles. God bless. I'm sure you're called to something more as well, Patsy, by the way. We're not going to let you slip away. We're just saying it's great to see other people doing it. There's a call to action here for everybody. You've received and you're inspired. And I just want you to be also motivated to be thinking about how you can step out of your box as well, come out of your comfort zone a little bit, and you can have support to do that in terms of developing something. Remember, we talked about that in resilience, about a side hustle of some kind as well to develop yourself, to develop yourself and to make a contribution, because we all have gifts and talents, and so we must make a contribution. So Bridgette is saying, this is great. It's so important to hear about prostate issues as it can affect our family members. So good to hear from approachable doctors. Patsy, again, this is great. And can we have more of this, not just because it's Black History? Absolutely. Black History is 365 days a year, Patsy. I agree with you. Gina, excellent host and amazing speakers, thoroughly enjoyable. Thank you, Loxley and Pat. So this is from Gina. And apart from, you know, calls for it to be on ITV and everywhere else. Lisa saying
we'll get
there. It would be fantastic if these programs could continue beyond Black History Month. Pat, Loxley and Michelle, I thank you for the invite. And although I appreciate that this is a huge amount of work, preparation, it is so important. It needs to be monthly. Thank you. And then the final one, there's thanks so much for organizing this. Brilliant speakers. Michelle, you've done well. Thank you so much for everybody's commentary. Loxley, I'm going to hand you the last couple of minutes now.
Thank you, Michelle, and thank you very much for the speakers. We've gotten some fantastic comments. I think you've all been excellent. But I want to give a shout to the host. This was sponsored by UNISON Black members. Unison Black members well, we can call it newly formed, but this was our catalyst now. We've used Black History Month to really start Unison Black members. What we need you to do, we need you guys out there to become involved, right?
Yeah.
We are, and I always say this, I'm going to say it again, we are stronger together. Yeah, as a united voice, we are stronger. And I promise you, together, we can make change. So I would say personally, if you're not a Unison member, join up, come on. You may have had a bad experience in the past, but I guarantee you, come and see me and I'll change that for you. We need to stand together, right? Come together. If you're not a part of Unison, if you're not part of the Black members, come and see me.
Lovely. I think that's a great call. So that's a call to action as well. To join Unison. You see you've got two very dynamic and interested leads here from Unison, both Loxley and Pat. So approach them and find out how you can join Unison and be able to access all of the services that they have to offer their membership. How can we come involved and where can we go? Okay, so I think your first port of call would be Pat and Loxley. And I think Pat and Loxley, I'm quite happy to sit with you guys to work out some next steps, actually, to capture some of these folks who are wanting to actively get involved now, so that we don't lose them because we haven't actually put a plan together to capture them, okay, and to support them. Well done, Unison Black members. We are definitely stronger together. Here, united in Unison. Do you need to be in a job to join Unison? Loxley, do you have to have a job to join Unison?
Well, actually, I might. I don't know whether Gina's still here. Gina, the branch.
She's there.
Hello, hello all.
Hi.
Hello there. You do have to have a job to be obviously working and paying your monthly subs as well. But you have to be connected to a branch, and we are the UCLH branch, and we cover a number of hospitals and private companies as well. So yes, you do need to be in work, and it doesn't mean, it could be any job at all. We take on everybody: nurses, auxiliary, HCAs, porters, catering, admin. We support everybody through difficult times. We have an organisation called There For You, who assist on the financial side. And obviously these times are hard, and we've been able to support many members through this. We take on everybody's problem and we try and make a difference and change. And we have an amazing amount of reps throughout all of our branch who make a big difference. So if you're not a member at the moment, if not, why not? Sign up. And like I say, that do see Loxley and Pat or myself as part of the trust. We have our own intranet website on the hospital. We have our Twitter. We can submit all the details. We've got Facebook. We're getting a bit more known out there now. So, but I'd just like to say on behalf of Michelle, the speakers, amazing Pat and Loxley, how much work you've put in on top of your day job. It's not gone unnoticed. So thank you very much. A big round of applause from everyone, I'm sure. Thank you.
Thank you, Gina. And I think an important point to note is that the union is not just for when you run into problems. The union is there to support you in your development as well, right? So don't think about union only, oh, I don't have much problems at work, so why should I join a union? So, it's about your own development, and there's services that the union offers. Am I not right, Loxley? It's not just about problems.
Absolutely, not just about problems. We can help you develop. There's so many things we can do for you. But you need to get involved. You need to come and see us.
Okay, terrific. So we've gone past the hour of 8 o'clock. It's now 6 minutes past. And we've done pretty well because we didn't really start until about 10 past 6, just waiting for everyone to come in. Oh, Jacqueline, I'll give you this opportunity very quickly to say something within 30 seconds since you put your hand up. Go on. Unmute yourself.
Okay, Jackie. Hi, Jackie.
Hi, I just want to say thank you so much, because I've had 4 sessions and I've learned so much and I've shared so much. So thank you to Pat and Loxley, and Michelle, you are an absolute superstar.
Oh, bless you.
Thank you, Jackie.
Thank you, Jacqueline. I can give you an extra 30 seconds for that. Thanks so much for speaking. for your comments, and we're so glad, so happy that you're here with us, and you attended each one and have gotten so much from it. So we need to capture these views, guys, because this is how you show your impact. All right, so we got to work on how we're capturing an evaluation at the end of this. Okay. All right. Thank you so much, Jacqueline. Thank you so much to the doctor, if she's still here. Thank you to Bridgette as well for your for all the work you're doing, actually championing the cause of female patients, Black patients in the NHS. And thank you to Loxley and to Pat. Good night,
thank you
all.
to Ernest. He's fantastic. He's our IT man.
He's your IT guy.
Working behind the scenes, but he's just amazing.
Wonderful.
Thank you, Ernest.
Thank you, Ernest. And see you all on the 30th is the next date. Am I right?
Yes.
I think the midwives are having something on the 28th.
Yeah, the midwives are doing something on the 28th.
But this group again will be, the next session will be the 30th. You don't want to miss that because it's going to be such fun. Spoken word, entertainment. I wish I could say food, but bring your own food.
Bring your own food. That's it.
Okay, good night all. Good night all. Pat and Loxley, you'll stay on.
Take care. Thank you, Bridgette.
See everybody out.